I'm Dr. Jam Kothari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Good morning, Sally. Good to see you again.
Hi, Jam. So here we are, another recording. Sort of recently back from Milan at one of our conferences, but it's nice to see you again. It was great to hang out last week, actually, wasn't it? And catch up with old friends and chat about the podcast and all that's happened just in the last week in terms of myeloma.
Myeloma has been a hot topic.
Hasn't it?
One of the top articles trending on the BBC website was about the drug that we're going to talk about in today's podcast. It's also currently Myeloma Awareness Week. And I've seen, and I'm sure you've seen as well, some brilliant stuff from Myeloma UK and other partners about how to recognise the symptoms of myeloma. And one of the key things is, of course, trying to diagnose the condition earlier.
Yeah, it's so important. And there's a huge area of research activity looking into this, isn't there? Particularly in terms of what we may or may not be offering patients, but also what causes myeloma in the first place. So really great to be part of the conversation today with you. And really what a fab opportunity as well for us to talk about this new combination, which has really hit the headlines and cut through, I think, to a really exciting development that we now have available to us in the UK.
I think what was lovely is that when it came out, and all the media was around it about 4 or 5 days ago now, I was sent the article about 20 times by different people, which was actually really lovely because people were reading about it, understanding it, asking me on what I thought about the article or isn't this exciting? And it's great because there's lots of health stories in the news on all sorts of different topics, and cancer is always topical. So it is relatively unusual for myeloma to be right at the top of that agenda. But it's great that it was because we want people to understand it and we want people to know about these things.
Totally. It was the same for me, actually. I mean, I got a text at like 6 a.m. from my brother-in-law who'd listened to the news at 5 o'clock in the morning and it was all over it. So no, it's fantastic. And, let's get more myeloma in the news if we can, as long as it's good news stories. That's the important message. Let's do good news stories because there's a lot out there to talk about.
Yeah, I think maybe what surprised me the most about this is that some people sent it to me. It's like, oh, wow, you actually know what I do. So that was actually quite surprising. It's like, oh, yeah, you're a doctor. And they ask me about things that I don't know much about, like I've sprained my wrist. It's like, well, can't really help you with that. But it's a perfect opportunity to talk about this new combination of drugs, which is now available on the NHS for select groups of patients. So what's the combination, Sally? And let's get going.
Well, first in the world, so aren't we lucky? So we're experiencing this in real time ahead of the curve, which is unique, isn't it, really? But yeah, so this is a combination of 3 drugs. One of the drugs is the breakthrough drug, which is the one that's been really cleverly labelled as the Trojan horse drug. And it was interesting, wasn't it, at the meeting in Milan? Everyone was saying, God, why don't we think of that? But anyway, so the Trojan horse drug, which is the one that hit the headlines, is called belantamab, another mouthful. It's also, as every drug tends to have 2 names, goes by Belamath. And then the 2 other drugs that it's been proven to work very well with, is Velcade or bortezomib, which we've spoken about on previous podcasts, and our old friends, steroids.
And this is a feature of drug development in myeloma, is that when a new drug comes along, sometimes the first thing you'll hear about it is, well, does it work by itself? And then if there is evidence that it does, then you combine it with drugs that work really well. And often you do increasingly get good results. So it is a very interesting combination and it's starting to get prescribed literally this week. We've just finalised our protocol in Oxford and we have colleagues talking about it and we're going to be using it really from now. But belantamab, I mean, Sally, who comes up with these names for drugs? People often ask me, it's like, how do drugs get names? And I've asked lots of people about this and I've never really got a good answer.
Yeah, I don't know. You wonder if people are just in a room all day brainstorming until they come up with something which is particularly tricky to pronounce. I mean, the mab bit on the end, that speaks to the fact that there's a particular type of drug working in a particular way. But I guess before we launch into that, because I think it does warrant a little bit of explanation, we've both been using this drug for a while, actually, Jam, haven't we? This isn't brand new to us because we were able to get hold of it from the pharmaceutical company to use by itself in people who unfortunately didn't have many other options. So, whilst this is new and we can prescribe this regimen, which is the combination of drugs together as of this week, actually the drug itself, we're lucky. You and I are quite familiar with it, aren't we?
Yes, we've used it in that way as you've described, which is so-called a sort of compassionate use program. And we've also used it in the clinical trials that have led to the approval of these drugs. And that is helpful because that allows us to more quickly understand and recognize the side effects, toxicities, but also we've seen the benefits in groups of patients as well. So when any new combination comes along, absolutely, we're really excited in the benefits that it offers, but also it's really important to understand the side effects and how they may affect people. So Sally, what group of people are going to be eligible to use this combination of drugs, people with myeloma?
It's a really important question because I think when you hear this news, everyone wants to find out more and know if they can get their hands on this drug. And as we've spoken about in previous podcasts, the way that we are able to look after people with myeloma in the UK is often defined by which treatments they can have when. And often in the UK, you are able to give a treatment when it is proven to work at that point in time for that person. And that's certainly true of this regimen. So, for example, if someone walked through my clinic tomorrow with newly diagnosed myeloma, as much as they might know about this drug and be very excited about it, I can't yet prescribe that for them because they haven't had any other treatment before. But we are now able to prescribe this combination of belantamab, Velcade and dexamethasone to people who have had what we call one line of treatment before. So that's a whole block of treatment. The treatment has controlled their disease and then the disease has come back. It does also include, just for clarity, those people who have had a whole block of treatment, fortunately small numbers where that treatment hasn't worked and they need to move on to something different as well. And there's one other sort of caveat with this prescribing, and it can relate to the treatment you've had previously, in particular that you've had lenalidomide previously, which we've spoken about on previous podcasts, or if you haven't, that you didn't get it for a good reason, because you're unsuitable, for example, it wasn't the right drug for you at that time. And then at the moment, that's the only group of people we can prescribe this in. So if you've had 2 or 3 different types of treatment previously, for example, you won't be able to access this drug at this point in time. Or this combination.
What we're saying is that people who can have this combination are at first relapse, essentially. So it's their second therapy in myeloma, and they had to be exposed in their first line of treatment to a drug called lenalidomide, which we have talked about in previous podcasts. Okay, so that's perfect. And as you said, it's a 3-drug combination. Now we should probably get into this Trojan horse thing. I'm not a classicist, but someone from Troy entered a hollow horse and then caused a lot of problems. And that's basically, in essence, how this drug works. That's how I'm going to be describing it in clinic. So a lot of our listeners will be more au fait with bortezomib, or Velcade as we call it, and dexamethasone. But this drug, belantamab, or its full name, belantamab mafodotin, it's called the Trojan horse because the way it's termed, it's an antibody-drug conjugate. So, Sally, just break that down. We're not going to spend too much time talking about the mechanism of action, but I think it is cool and it is clever. It's a class of drugs used across oncology and different sorts of blood cancer as well. And it should be noted that this is not the first antibody-drug conjugate that we have used in haematology.
Definitely, but it is the first in myeloma, and that's where this could be a game changer, and that's quite important. And just to complicate things for our listeners, antibody-drug conjugates, we often abbreviate to ADC. So if you or your doctor ever refer to ADC, that's what you might be talking about.
We love a TLA.
We do. In fact, we could do a whole podcast. We probably should sometime on our acronyms.
I mean, that would be so dull. I mean, we'd be down to like single figure listeners. We'd know who our super fans are then, wouldn't we?
Christmas quiz, Jam. Christmas quiz.
Christmas quiz. All right, we'll save it. Although it's very un-Christmassy at the moment outside, isn't it? ADCs, absolutely. ADCs.
Yeah, ADCs. And we also really like in medicine to make things sound quite fancy and complicated. And you could often just take these individual words and translate them into something which is just much easier to understand. So if you look at the antibody component of that, and we're all very familiar with antibodies and what they do, partly because of COVID actually, but an antibody is a type of protein that latches onto something else. And this is what the part of this drug does. It's a protein that hones to a particular, or finds another protein on the myeloma cell. And actually the other sort of type of cells which aren't myeloma but are quite similar, and sticks itself onto it. And then there's a drug, that's a D bit in the middle, the drug, which is a drug. And conjugate is a fancy way of saying there's a drug stuck onto that antibody. So there's a drug attached to this protein which hones to the myeloma cell. And that's the best way of understanding it.
Yeah, and that drug is like a chemotherapy toxin. And then what happens is that the antibody finds its way to the myeloma cell. The antibody is attached, as you say, to this chemo drug, which then goes inside the cell, and the chemo kills the myeloma cell. So that's why it was and has been described as a Trojan horse. But for example, people with Hodgkin's lymphoma, we've had access to antibody drug conjugates in certain situations for a number of years. But as you say, this is the first time in myeloma. So we use this drug, this antibody drug conjugate, in combination with bortezomib and dexamethasone. So in terms of the way the combination is given, Sally, before people start treatment, there's various pre-assessments that need to be done. And something that we're going to spend a good bit of time talking about is a specific type of side effect, which is sort of unique really to sort of myeloma doctors as well as our patients, because belantamab can cause a number of issues in relation to the eyes. But before we get into that, maybe we'll just explain how the drugs are given when you give all three together.
Absolutely. So steroids, we know, are tablets. We know all the mischief that they cause, so we won't go over that again, but just watch out for that. And if you want to refresh your memory about that, do listen to our steroid podcast. The bortezomib, or the Velcade, we prefer to call it Velcade, is given as an injection under the skin. Now, in the study, it was given twice a week. We tend not to do that in day-to-day practice. And that's because if you give the treatment, the Velcade treatment, twice a week, you just see more toxicities in terms of the neuropathy we've spoken about on previous podcasts. So we give it, well, very likely in most places to give that once a week where we're able. It is important to say, however, that the study was designed in a particular way because I had to refer to what's been proven in other studies, and other studies in the past have given Velcade twice a week. So that explains why what was proven in the study might be different to what's happening in the real world. But we're, I think, pretty confident, to say the least, that if you give the Velcade under the skin once a week, it works just as well with fewer side effects. So really important point. And then the belantamab, so the new Trojan horse drug, that's given into the vein, so you need a cannula. I think it's infused over 30 minutes. Correct me if I'm wrong there, Jam. I think it is, isn't it? And actually, during the infusion, it's a bit of a non-event, to be honest with you. It just goes in some fluid, and then you wait for the magic to happen. First time you have it, there's a very, very, very small chance you could react, but really that is minimal. And after that first time you've received it, the risk of reacting to it, and by that I mean sort of your blood pressure changing, feeling like you're coming down with a cold, that kind of thing. But yeah, after you've had the first dose of it, I think that risk is pretty non-existent, to be honest with you. So you have it in isolation, and then you have all the supportive tablets on top, which is spoken about previously.
It's a 3-weekly cycle. So if you do have the Velcade twice a week, which some people will have, although I do think it will be a minority, and it should be a minority, you get Velcade twice a week for 2 weeks, then a week off. The alternative way is having Velcade once a week. And the way the trial was designed is belantamab initially was given every 3 weeks. And the steroids are given, usually around twice a week on the day of the Velcade and the day after. So you have one tablet, one injection under the skin, and one intravenous drug, the belantamab. And of course, the support medications, as you mentioned, Sally, and the bone protective medication, which goes intravenously once every 4 weeks. In practice, we have seen from the trial and also previous experience with belantamab that it often ends up being given much less commonly than every 3 weeks. Some people get it every 6 weeks, and even after they've been on it for a while, much less often. What we should say is that the Velcade is given for a fixed duration in this protocol. So it's given for normally approximately 24 weeks. And then belantamab as a single agent continues every so often, which in practice, from what we've seen and the data, can be from every 3 weeks to every even 3 to 6 months. I mean, some people are getting it very infrequently and given until it stops working or there is too many side effects or too much toxicity.
Yeah, and I just wanted to challenge you on that a little bit, Jam, because I think a lot of people listening might think, well, if you're not giving it so often, it's not going to work so well. Can you speak to that a little bit and what we understand about it?
And this is relating to the toxicity, or one of the main toxicities of this drug. As it was developed, it was clear that one of the side effects of belantamab mafodotin is a number of effects on the eyes. There's a layer in our eyes called the cornea, and this is the sort of transparent layer at the front of the eye. The drug that is attached to the antibody, which is like the chemotherapy payload, as they say, the inside of the Trojan horse, can cause this side effect in the eyes, which is called keratopathy. This can cause blurring of vision, reduction in what we call acuity, and a number of associated eye side effects, like feeling like you have something stuck in your eye, which can be very unpleasant actually, or dry eyes, or sometimes even people get streaming eyes. But side effects that have a significant impact on day-to-day living. And I think with a lot of careful investigation and understanding, and working very closely with our ophthalmology colleagues, a big shout out to those eye doctors. I love you guys. You're very different to hematologists, but we've worked very well together on this.
It's a beautiful marriage. It's a beautiful.
I mean, seriously, have you ever seen an ophthalmologist using chopsticks? I mean, I've never seen such precision, and it gives you so much confidence. It's like, if you're messing around with my eyes,
hilarious.
That's how I want to see you using all sorts of cutlery. I love it. But honestly, I am digressing now. How did we get onto Chinese food? And what's been found with lots of careful understanding is that there are a number of mechanisms of minimizing the eye toxicity with sort of treatments, and Sally, I'll let you get into that. But what we've seen is that if you space out the dosing and reduce the dose, you can very much continue the drug and eye side effects get better. And we know from the trial that led to the approval of this drug that people who did very well, a lot of them after a number of months ended up taking this drug very infrequently.
I think that's a real win for this combination of drugs, actually. It's just actually, once you're established and it's working, you may only need to turn up every couple of months or so. And I think that might be quite appealing for some patients. So, we look forward to using it in that way. But just to pick up a little bit on that eye piece, Jam, because it is really important.
It's really important, yeah.
Yeah. A few really key messages there, just for those of you who might be starting on this regimen, is first of all, please tell your team if you're getting eye changes. I mean, you will be being reviewed by an eye specialist anyway, but that impact it's having on you is incredibly important in terms of, again, your quality of life, but also just day-to-day stuff like, can you read? Are you able to read? Is the text clear? Is it a bit blurry? Can you watch the TV? And really importantly, are you okay to drive? Because actually, if your eye's a bit blurry, you have to take that into account. It's incredibly important. I imagine most of us would be able to say with a degree of accuracy, actually, it is a bit blurry when I drive. I am finding it difficult reading, and that just needs to be shared. It's also really important to say, because I really want to shout out, that in nearly all cases, the blurring of vision, if it occurs, the dry eyes, the irritation gets better. So this is not a permanent state of being. But what you do need to do to enable the eyes to heal is perhaps pause the treatment, or certainly lower the dose, or both sometimes. And then that just allows the eyes to get a little bit better. And then if you talk about the damages that occurs within the cornea, what you see are small cysts, and they tend to occur if you've had the treatment and there's excess drug almost sort of floating around in the system. It sort of hones to the eyes. And when that happens, it happens on the outside of the eye to begin with. And so the toxicity that you get from a treatment, or this side effect, you may not notice at the very beginning, because the outside of the eyes, the periphery, is not where we see. We look through the middle of our eyes, our pupil. And so you might get this sort of delayed change in your vision, and then you go on to have a little bit more of the treatment, and then those cysts sort of move to the centre of the vision, and then you notice it. So it's a very dynamic situation, and that's where our eye specialists are so important.
Well, it sounds like, Sal, you're an eye specialist now, but that was a lovely description. So thank you. We should highlight that it's very, very common to get eye side effects with this agent. In the trial that led to the approval of this combination, 80% of people got some kind of eye side effects. And we should say that in this population that was studied, who makes up that 80%, there weren't many patients over the age of 75. And as always happens in the real world, you're using the combination in a different population who are less fit. People will be older and may have picked up other eye-related problems unrelated to myeloma, which could make these eye side effects a bit worse than what we saw in the trial. We don't know, and we will be collecting all of this data moving forwards. But it's important to understand that it's very common, but Sally, as you say, increasingly better understood, and in the vast majority of people, not permanent. And that's because the cornea is a living organ and new cells are continually made. And understanding how you reduce the dose of the drug, you space it out, really does make a big difference. Sally, what about the other, what we call eye-specific supportive care for this drug? And how do we work with our sort of eye colleagues, optometrists and ophthalmologists with regards to the assessments? Because I definitely can't use an ophthalmologist. I can't even pronounce it. An ophthalmoscope. Not only can I not use it, I can't pronounce it, but actually you need a proper, what's called a slit lamp investigation. I'm not going to go into a segue about how I went to the optician for the first time in my life last year.
Joys of getting older.
We'll save that for another time. But what supportive care and how are we going to work with our ophthalmology colleagues?
Yeah, I think this piece will evolve with time as well, a bit like the management of other drugs has evolved. But at the moment, I think in most places it's set up such that before you're due to see your haematology doctor, so us, and particularly before you're due your next treatment of the belantamab, you see your eye doctor to assess the extent to which your eyes may be affected so that they can then advise and say, actually, there is damage in this eye at the moment, and so actually we should perhaps pause treatment or lower the dose. And so the way we tend to talk about side effects is grading. And so if you go and see your eye specialist, they may share with you the grade of the eye damage. And that allows us to basically figure out if you're going up a grade, things are getting worse. And if you're going down, it's getting better. So it allows us to assess in real time. But what I suspect will happen in the future is increasingly we as haematologists will be able to become mini ophthalmologists and assess people's vision using those charts where you read off the letters and such like, or indeed according to symptoms. And there's some research going on in that area. But to support people now, because this can be uncomfortable, I don't think it's painful, Jam, I hope you agree, but certainly uncomfortable, the grittiness. We certainly recommend drops in your eyes 4 times a day just to help soothe the eyes. In terms of those visual changes, it's just waiting for time really to pass. And it's important to say that some of the data suggests that the eye changes can get better within as little as a month. Sometimes it might take a little bit longer, up to 3 months to completely resolve, depending on how severe they are. So yeah, that's kind of roughly what we do. But watch this space. I think that will change with time as we learn more and we're able to actually do some of that piece of work ourselves in clinic.
So eye drops, I think, are really important 4 times a day, and they should be continued all the time. People are on this agent. Sally, what about eye coolant masks? Is there a role for these?
Do you know what's interesting? So I remember we were in Oxford going to see the patients on belantamab. When was that? A good few years ago. And then one day, all these eye coolant masks appeared. And I was like, what's going on? You know, they look very fancy, but I'm not sure of the data around that. I know that they can be used. I know that you guys are using them, but I'd be interested to hear whether you found that they were soothing for patients when they're having their treatment.
It's hard to say, isn't it? We've left them as optional on our protocol. The thought being that if you sort of cool down the cornea whilst the drug is going in and maybe is at its highest concentrations in the blood, the cooled cornea doesn't get affected by what we call that off-target effect of the chemotherapy drug attached to the antibody. So it's one of these things that I think sometimes can be of use and it isn't a big intervention. But as you say, I don't think there's any really good data to say it makes a big difference.
I agree, but it might feel nice, even while you're there, allow you to have a little nap while you're having your infusion on the unit. Who knows, and actually if it makes you feel nice while you're there, why not? That would be my advice.
No, I think that's great advice. So technically people should have a formal eye assessment before the first 4 doses of this agent, belantamab, and then as is deemed sort of clinically necessary on the basis of symptoms and other previous changes that have been documented by our eye specialist colleagues. So often an optometrist would be able to do the assessments that are required to help us work with you to dose the drug appropriately. And occasionally also ophthalmology doctors will do those assessments for us as well.
Definitely. And there, every hospital, particularly in the UK, has its own unique pressures. And there may be some departments in the UK where there aren't a lot of eye doctors. And so actually seeing quite a lot of myeloma patients every 3 or 4 weeks, or however long it might be, could really be a bit too much for them in terms of workload. So opportunities are being explored about using other optometrists or community specialists to perform those assessments on behalf of the doctors in the hospital. Really important to say that if whoever's listening goes on to that treatment and they are being seen in the community, sometimes by commercial specialists actually as well, that they are getting the equivalent care. They are getting the equivalent assessments as they would do in the hospital. It's just finding the provider that suits for your healthcare infrastructure or the facilities that you've got available wherever you're living.
So we should also talk a little bit about other toxicities from this 3-drug combination. We mentioned the steroid-related side effects, the neuropathy related to bortezomib or Velcade, and also fatigue and diarrhea, which are, unfortunately common side effects of a number of combinations. In terms of infection, I think a real benefit of this combination is that, yes, like as with any chemotherapy combination, there is a risk of infection, but the risk of serious infection with this combination, I have to say, does appear relatively low, Sally.
Agree, which is a win because infections are always on our mind, aren't they? In the myeloma patients that we look after, because it can be very problematic, but not such a concern here, which is great.
And one other thing to keep an eye on, there is a signal for this drug belantamab affecting liver function. So a couple of what we call the enzymes, the markers in the liver, can go up to quite high levels. But certainly this does look very reversible, but it is always important to keep an eye on liver function.
Yep, definitely. I very much agree. That's been noted. And also your platelets are there, the small cells in the blood that help your blood clot. Both the Velcade and the belantamab can cause them to fall. So if you're on additional blood thinners or if your platelets are a little bit low before you start, your doctors might be a bit more interested in monitoring them to make sure they stay within a safe range.
3-drug combination, and the question that we get asked every time we're starting a new treatment is like, this sounds good. But how long is it going to work for, Doc?
My answer to that, which I promise isn't a fudge jam, because it is that everybody is different. So when outcomes are reported in clinical studies, those outcomes are born on what we call the median. So that's if you had 100 people starting a treatment at the same time, the median is the time at which the 50th person, so person number 1 relapsed first, number 2 relapsed second, and then the 50th person is a median. So 50% of people will be on treatment for longer than that number quoted. 50% of people will relapse before that. But based on the study, which is looking at lots of different patients in terms of the treatment they had before, it's reported that you can stay on treatment for up to 3 years, maybe slightly beyond that, for that 50th time point. However, in people who have been exposed to lenalidomide and where the lenalidomide stopped working, the time may be shorter. That 50th time point may be closer to sort of 2 years approximately. So it very much depends on what you've had before, but also how your myeloma has behaved before. So if you had a very long, durable, deep remission to that first block of treatment, it's quite likely that you'll have a lovely long remission to this one. And unfortunately, the same also applies to those people who didn't get the response for as long as they wanted first time round. It may not quite meet the sort of that average, that 50th time point this time round.
It is very individualized. And as you say, I think the majority of people that get this combination will be in that group who've had lenalidomide and lenalidomide has stopped working. So as you said, Sally, it may be an average of 2 years. What I would say is that if you do start this combination, certainly in terms of starting it within the NHS, your case would be discussed at the MDT meeting, and there are alternatives as well. And this may not be a treatment for everyone. And I think it's important that when that is discussed with you, the alternatives are also discussed and it's clear why this combination has been chosen for you. But we do anticipate that a number of people at first relapse will be getting this combination, as we said, starting from this week.
Yeah, it's brilliant, isn't it? And just to add to that point, Jam, a little, I think, We are delighted there's a new class of drug available. We're delighted that we're able to now prescribe this treatment in the UK. Don't want to take away from that and the opportunities it offers for our patient population. But we're also delighted about all the other progress with all the other therapeutics. So there are many more options that also exist in the myeloma space. So, for example, if you were having a conversation with your doctor and they said, oh, you could have belantamab, or you can have a clinical study, or you could have this, or you could have that, I would recommend exploring all of those options, because there may be a very good reason why one particular treatment option is preferred for that individual patient as opposed to another. So, yeah, it's fabulous that we've got this, but those other options still exist as well.
So just to summarise, it's a 3-drug combination, belantamab mafodotin, Velcade and dexamethasone. Belantamab is this new type of agent, this antibody-drug conjugate, which is given intravenously every 3 weeks initially and then less often. It's got a sort of unique eye-related toxicity that in the vast majority of people is reversible and requires input from our ophthalmology colleagues to ensure that we are assessing people accurately and reducing the doses where appropriate. The Velcade and dexamethasone are drugs that people are much more familiar with well understood toxicities, and it's going to be available for NHS patients, certainly in England and Wales, from this week.
Yeah, it's great news. It's a brilliant timing in terms of Myeloma Awareness Week. And please get in touch with us if you've got any questions.
Thank you very much, Sal. It's been great chatting to you, and I'll see you at the next one.
See you soon.
This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.